Kia ora everybody, I'm Lisa Hoyle, I'm a health psychologist working at Counties. The psychology of diabetes is a massive topic and I could have probably done a full day workshop on it. So I just chose 4 things that I hope you all think about the next time you come across someone with diabetes. Number 1 is rapport, and I'm really hoping this is not new information to you all. Time and time again, research has showed that if we ain't got rapport, we got nothing. It's really, really important to have a good relationship with our patients. And it's been shown that it improves treatment satisfaction, adherence to whatever it is you're asking them to do, and that improves treatment outcomes. So it's really, really important. Main ways to make sure we're having a good relationship with our patients is whakawhanaungatanga. This is a little bit different to when I trained as a psychologist. We were told you don't tell them anything about yourself, but actually we now know that's quite unhelpful because what it means is that they don't connect to you as a human being, and we do our best work when we're at our most human. And so in that way, it's really, really simple. You don't have to tell people where you live. You don't have to tell people what your children's names are, but just something that shows that you're a human being. Are you going to watch the All Blacks tonight? I see you've got a Puma hat on. I've got Puma shoes. Just something, anything to connect that's outside of their diabetes. One I've started using is actually to tell people why I wanted to become a psychologist. What's really cool about that is that it instantly connects with my values. And so thinking about you, where you work, you might find that really helpful to tell people why you became a nurse or a doctor as well. And that, it's always because we want to help people. Instantly you're connecting on your values. Open questions, following what the patient wants to talk about and matching where they're at are really, really important. And we do see time and again where there's a real mismatch and it means the person doesn't follow the advice. So they come in and they're not taking any medication and not, following the diet advice and exercise advice and yada, yada, yada. And we dump it all back at them and tell them to go away and do all of this stuff. Complete mismatch to where the person's at, rather than if we just ask them to do one small thing, can be really, really helpful. And the last one, remembering to care for the patient and not the disease or the computer in the labs. And I'm very excited about the technology that you're using in primary care. I saw my own GP recently and they didn't sit at the computer because they had the technology that recorded what was being said, and I think that's a real game changer. Diabetes distress is the next one I wanted to talk about, and I purposefully left a gap between di and diabetes because I cannot count the number of patients who have said to me, when I got told I had diabetes, all I heard was that first syllable, di. And that's what happens in my whānau. When you get diabetes, you die. And before you die, some really horrible stuff happens, like you lose your limbs, you end up on dialysis, you go blind. So for a lot of my patients, and I'm sure a lot of yours, that's their reference point for understanding diabetes. No wonder we have really high rates of diabetes distress. So diabetes distress comes from the relentlessness. You don't get to have a break when you have diabetes, and also the emotional distress that diabetes causes. And that does come from their experience, the trauma, the intergenerational trauma that diabetes carries, the burden of disease. And also we often pitch diabetes that we need to be really perfect with its management. And that's really, really unhelpful because there just is no perfect and it sets people up for failure. So the stats, so some studies have shown that 80% of people with diabetes experience diabetes distress. So if you worked yesterday in clinic and had 10 people with diabetes, that's 8 that probably had diabetes distress. We think it's really unrecognised and a hidden cost of diabetes, and probably we could be doing healthcare a little bit differently to address diabetes distress, especially because it leads to non-adherence. So these are some cool questions that myself and colleagues have come up with around trying to really help elicit what's getting in the way for people and help them problem solve that. So everybody that walks in, I will assume that they're not taking their medication perfectly because we know that most people don't. So I'll say, what's getting in the way for you taking your insulin at the moment? What's difficult for you right now is another one my colleagues use. What's the hardest thing about diabetes? The bottom one comes from a guy called Bill Polonsky, who is an American psychologist who wrote the Diabetes Burnout book, which is an absolutely phenomenal resource for helping people overcome diabetes, burnout and distress. So he asks everyone, what's driving you crazy about diabetes? What else can we do? We really have to normalise and validate. If we know that 80% of people are probably struggling with this, it's a really normal human experience. And when we normalise and validate, it really allows people to be open with us and get the help that they need. We need to remove the stigmatising language because that leads to guilt and shame and people not wanting to be open and honest with us, and as well as anxiety, depression, distress. The best word that we need, the word that we probably need to change the most is the idea of testing blood sugars, and I was really excited to see that the previous slides had done that. So that's swapping the word test for a word check or monitor. So monitor your blood sugar levels or check your blood glucose levels is much better. And I'll show you why. What pops into your head when I say the word test? Exams? Pass, fail, school, good, bad. We don't want to feel like that when we're checking our blood sugar levels all day, do we? So it's really important. Similarly with the language around poor, good. And also talking about complications. When you're scared of something, you avoid it. That's a natural human response to anything we're scared of. So if we're scared of complications and that's all that's talked about at our appointments, it actually makes us want to avoid looking after our diabetes, which is the opposite to what we're trying to achieve. So it's really important that we're presenting that in a balanced way and talking about what's going well. Another thing with diabetes distress is thinking about that, will this extra thing that I'm asking them to do make their distress even worse? And if so, now's really not the time to be doing that. And like we've already heard, technology has been a game changer for managing diabetes distress. The next one is similarly diabetes burnout. And why do people experience it? Because they don't get a break, don't get a holiday. It's not like work where you can take some annual leave, you can call in sick, you can change jobs if you need to. We don't get to do that when you have diabetes because the burden is all day, every day, relentless. And the way healthcare is set up, it really allows people to feel like a failure. We're constantly checking things like HbA1c and your glucose targets and checking blood sugars and then food and diet and all of that stuff. And so it can really feel like a failure for a lot of people. So what do we want to do to beat that? Acknowledge that it's real. I've had a lot of patients that I just explain diabetes distress or explain diabetes burnout, and the weight comes off their shoulders. They're not alone anymore. And so I think that's really, really helpful. Setting realistic goals, and I think that was already on the CGM slide as well, that it's not a failure, it's more information. So if someone has higher readings, it's not a failure. We've just got information that whatever we're doing right now isn't quite working. We need to do things a little bit differently. Make sure we've got a safe space. I know in primary care you're really stretched for time. I have the luxury of hour-long appointments with everybody that I see, and I appreciate you don't have that luxury. However, research has shown that when you do use open questions, using silence and empathy, rather than having those quick-fire closed questions, it actually can save you time in the long run. I know that's hard to swallow when you've got back-to-back patients and 6 minutes to see them all. And acknowledging what they are doing and what they can do, which a colleague told me this really cool term recently called strength spotting, which is the idea that, if there's this flood of things not going well, find that one thing that is, and really honing in on that, because we know that people, they spiral down with depression and anxiety, but we can also spiral up. And so sometimes that's a way that we can help people, spotting the strengths that they've got, or strengths that they've had in the past, and using those. And again, technology has been shown to improve diabetes burnout. One of the things that we know is that anxiety is possibly overdiagnosed in people with diabetes when really it's diabetes distress. And similarly, depression is probably overdiagnosed in people with diabetes when really it's diabetes burnout. And why that matters is that you may completely miss the boat for treating the person if you don't address their diabetes, their relationship with their diabetes and what they're thinking about their diabetes. The easiest tools you guys will have in primary care are these questionnaires, because I appreciate the time pressures. The problem areas in diabetes questionnaire, the PAID, I use that whenever I'm stuck and I'm not quite sure what's going on for the patient. I'll pull the PAID out. It has never served me wrong. It has always uncovered that hidden thing that's keeping the person stuck with managing their diabetes and us moving forward. Similarly, the diabetes distress scale is really, really useful, and the brief illness perception questionnaire. All of these are freely available, just Google them and they should come up. I would love someone to do some research in primary care in the community and what's going on for people with diabetes, because there's lots of stuff being done in secondary care, but I'm really curious to know what our rates of diabetes distress are and burnout within the community. That would be really, really helpful. Needle anxiety, I put this in because it's the number one thing I get asked about whenever I present. Really, really common. You will all have seen people that struggle with needle anxiety. One of the top reasons why people don't go to the dentist, one of the top reasons why people don't take their insulin or check their blood sugar levels. Don't assume that because someone's had diabetes for a really long time that they don't have needle anxiety. I work in renal as well, and I've had many people turn up pre-dialysis, needing to start dialysis, who have said to me, I've never taken my insulin because I have needle anxiety, needle phobia. Also don't assume that because someone can take their insulin means they're okay with their HbA1c. I've even had people that were fine with HbA1cs, fine with insulin, but it was the finger checker that they couldn't manage. There's lots of there's different types of needle anxiety, which I find really useful, working out is it the blood that they're struggling with or the needle itself. Lots of strategies you can use. You're probably seeing a theme, normalising and validating. Our gold standard for treating needle anxiety is exposure therapy or in vivo systematic desensitisation. And there's lots of stuff freely available on the internet to help. There's also stuff on health pathways, and NZSSD is going to be putting out some guidance on that soon as well. The diabetes SMOs tell me as well, if they switch the needle size, so prescribing a smaller needle, that's found to be really, really helpful. And again, technology has been a game changer. Some of the Starship doctors tell me they barely see needle anxiety anymore because they just give people CGMs and insulin pumps, which is amazing. So I know I spoke really, really fast, and that was a very quick overview. So I would love any questions if anyone has anything. No?